Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. You know me, I'm your host, Dr. Alison Kole, and today I'm again joined by Dr. Ruchir Patel. He is a sleep medicine specialist based in Arizona. And today, the reason I want you to be tuning in is because Ruchir's been on the show before. He really understands hypoglossal nerve stimulation, which has become almost synonymous with the word inspire. Everybody's been seeing the commercials. There's this surgery for sleep apnea. And he perhaps is, one of the sleep specialists that has the most experience, I think, in the United States. I mean, you're amongst that. Like, you really understand hypoglossal nerve stimulation. And now there's a newer device called Genio. And so for my listeners, I want you to stick around so you can learn about what's new on the horizon for hypoglossal nerve stimulation. So we're going to be kind of talking about both of these things and kind of how they compare and where Ruchir sees the role for Genio in the future. And I want to just state for the record, to be in full transparency, our disclosure. So there is a potential conflict of interest for Ruchir, which is that he is currently the vice president and senior medical director at Inspire Medical Systems, and he was previously recognized as the Inspire Care Team of Excellence physician. So he has a lot of experience working with Inspire. However, we're both clinicians, and I need someone with his level of expertise to really talk to me about what this newer product means and where this might have benefit. So Ruchir, thank you so much for joining me this morning. Of course, he's on the West Coast, so he's been up early. We were just talking about how he starts his day so early, and I'm so impressed by that. I'm not a 5 a.m. club person. I do get up early, probably closer to around where your wife and your son get up. But
I'm in bed by asleep by 9 p.m. So I do get my 7.5 hours.
Yeah, my husband's the same way. Like he's in bed. He's like ready to snooze at like 9:30, and I'm like, I can't. My brain is not ready to power off yet. So, Ruchir, there's been the DREAM study, which is for Genio, and we have the original STAR trial for Inspire. Let's level set by just explaining hypoglossal nerve stimulation. Let's start with that and the basics, and then maybe we can get into what the nuances are between the two different products that are now available.
Yeah, sure. So obviously hypoglossal nerve stimulation, Inspire Medical Systems was the first to market. They introduced our unilateral stimulation device in 2014 is when we were FDA approved after the STAR trial was published. And it's a treatment option. Hypoglossal nerve stimulation therapy is a treatment option for individuals that, could not tolerate CPAP or did not receive benefit, that have moderate to severe obstructive sleep apnea, that need an alternative therapy, right? And I think that's a major topic of discussion as well, likely within this context or separately of, those patients that just aren't getting treatment because they can't tolerate the traditional treatment modality that we're all, as sleep specialists, accustomed to prescribing so often. But in essence, the therapy is helping to keep the airway open by moving the tongue forward while the individual is sleeping to prevent airway collapse. Also helping to address snoring as well. So very simplistic therapy and design, but basically a form of invasive neuromodulation that's helping individuals to treat their moderate to severe obstructive sleep apnea without actually having to wear a mask and connect it to a PAP device.
And so with Inspire, we now have, it used to be 3 incisions, but now it's 2 incisions, correct? Okay.
2 incisions since actually 2021.
Okay. So a number of years we're doing 2 incisions, and it's, again, you mentioned unilateral, which means one-sided. So what you're doing is you're essentially having an electrode that connects to the hypoglossal nerve. There's another kind of probe that's going to be kind of in sync with what our respiratory muscles are doing. So we're kind of timing it and to how we're breathing that sort of activates it. So I look at it like a pacemaker. Would that be a correct way to describe it? Sort of a pacemaker for your tongue muscle related to your breathing?
Yeah, in essence. So, but also keep in mind that with Inspire 5, which is our latest generation device that was introduced in May of this year, there actually is no respiratory sense lead, right? So that was the prior generation of
Got it.
Inspire 4. Now the Inspire 5 is a completely in-house designed, implant that actually has an accelerometer built in. That's the same accelerometer that is used in many cardiac pacemakers. So that device is actually doing the respiratory sensing, right? And we presented data at the ISSS and the AAO last weekend, but even at World Sleep from limited market release from Singapore and the US, showing that the inspiratory phase overlap, meaning the duration of time that the stimulation is being delivered from the just at the end of the expiratory phase to just before the start of the inspiratory phase is actually even greater, meaning there's greater coverage of that critical period. So what we call precision stimulation with Inspire 5 because of the high sensitivity of the knee respiratory sensor built into the can itself. So it's still two incisions, but the procedure time actually has reduced on average by 20% because there's no longer the need to add the respiratory sensor that you were referring to earlier. So.
Okay, interesting. So we have this technology now where now it's kind of gotten even more sophisticated. The original STAR trial data, which was published back in 2014, when this is kind of new to market, really showed that they would do a drug-induced sleep endoscopy, put you to sleep, watch exactly how the airway closed off in order to select the patients. The AHI criteria at that time was more restrictive, and the body mass index was around 32 or below. That criteria has changed somewhat now. So can you kind of share with folks kind of what the clinical indications are, what's the upper limit, and what have you seen in terms of efficacy for Inspire with the sort of broader criteria of people being able to be heavier and have more severe disease?
Yeah, of course. So specifically for Inspire itself, the FDA label did change a few years back to the upper limit on the AHI increased from 65 events per hour up to 100 events per hour. And then the BMI criteria went from 32 to 35 up to 40 events per hour. I believe Medicare was following less than 32. Some of the commercials were allowing up to 35. Now the FDA label does allow for up to 40 kilograms per meter squared for the BMI. Otherwise, the other FDA indications still remain the same, but those are the two largest changes. Also, there was a new FDA indication, I believe it was in 2022, with pediatric Down syndrome as well. So, that's a vital population that has difficulty tolerating PAP therapy, as I think we've probably both taken care of children with Down syndrome. It can be difficult to have them wear a PAP device. So that was another new indication as well, a few years back. In terms of effectiveness, I would say in my clinical population, because I have about 500 patients with Inspire over the last 6 years, and the highest BMI that I've had implanted is probably up to about 38 kilograms per meter squared. Here in Arizona, we don't have a very large population of individuals with a BMI, approaching 40 kilograms per meter squared. I would say my average is probably closer to about 32 to 35, just based on our demographics, right? So it is going to be region specific, and that's something that I've learned over the years, discussing with other sleep physicians. But even with an AHI, I have patients that have an AHI approaching into the 90s. And of all age categories, most of them are probably going to be in the Medicare age category, but these folks have done quite well. The thing about managing hypoglossal nerve stimulation, whether it's unilateral, bilateral, doesn't matter. Let's just call it HN, right? Is going to be learning how to manage the programming. And I learned a lot myself. Inspire has a published care pathway that was published several years ago that kind of has step-by-step guidance in how to manage a patient from activation to the fine-tuned titration. I took that information and then kind of created my own, even more sophisticated care pathway for my own patients. And through that, I was able to learn and teach myself even more advanced programming and really learn how to fine-tune the patient, but even troubleshoot, right? Like a lot of things that we've done with my ENT partner locally in patients that still have residual supine AHI with Inspire therapy is we'll either do advanced programming, change electrode configuration, because one of the benefits of Inspire therapy is that we can tailor the therapy based on changing electrode configurations, which in turn, when you change the electrode configuration, it changes the way the distal branch of the hypoglossal nerve is being stimulated, which in turn can change how muscle recruitment can happen with the tongue base and change how the tongue actually moves. So there is the ability to customize it, and often doing either an awake endoscopy, or we've even employed drug-induced sleep endoscopy with Inspire to really visualize what's happening while this patient is quote unquote asleep, to be able to see, is there another programming that actually will result in even greater airway opening. Of course, when we're doing a DICE, the patient is supine, right? So it's kind of a nice time to be able to take a look. So I've done a lot of that, and that has really allowed us to fine tune these patients, even the ones that, others may say, hey, I can't get the supine AHI to improve. I can't get the REM AHI to improve. There are actually ways, but it's all a matter of really learning the sophistication of how to manage these therapies. And over time, I think as more and more clinicians engage and take the time to learn it, he or she will learn. It's just like, managing a CPAP and getting patients how to resolve the leak and how to fine tune the AHI, fine tune the PAP pressure. I mean, it's an art, right? There's science background, but it's an art when it comes to really managing these therapies.
And I think that's a really key point. And one of the reasons I really wanted to talk to you about this topic is because you have experience in making those adjustments. And we had spoken on our last episode that I was hoping you'd be able to create a manual to teach more people how to kind of fine tune it. Because I think that's kind of one of the limitations is people don't, there's like the handbook settings and then there's really getting into the weeds and kind of understanding what you can do to tweak it. So the fact that they have you working with them is huge. I don't know if you have any experience working with the Genio product as well firsthand. I guess that's the first question I would have. I just don't know if that you were involved in any of the initial trials or you have patients with that other form of hypoglossal nerve stimulation.
Yeah, it was not part of the DREAM study, or even I believe currently they have a study called the ACCESS study for CCC, complete concentric airway collapse. I wasn't involved in either of those trials. And then since FDA approval for the Genio implant, I believe the first 5 patients were just implanted, I believe, last week or the week before, I believe 2 weeks ago in Texas. So I don't have any patients with Genio at this time.
Okay. All right. So the difference in my understanding, which is really, I talk about zero experience. I'm even further than, but I have further experience than you because I had my handful of Inspire patients, but not 500 that I was programming myself. But Genio really is bilateral hypoglossal nerve stimulation, correct? Can you talk a little bit about the difference between Genio and Inspire? And why do you think Genio came about? It appeared in the paper, the DREAM study paper, that it was primarily because of that residual supine OSA issue that seemed to trigger the interest in whether or not they would, I guess, be a better bang for your buck if you did bilateral stimulation.
Yeah, I mean, there's several core differences between Inspire therapy and Genio therapy. I mean, the surgical process is very different, right? It's 2 incisions versus 1 incision, but with the Genio implant, the 1 incision is going to be submental. The product itself are very different. With bilateral stimulation, the device has 2 paddles that are placed, approximately below the hypoglossal nerve. It's not a precise cuff placement around the distal branch of the hypoglossal nerve, preventing the inclusion branches and other branches of the hypoglossal nerve that may result in alterations in how we want the tongue to move in this situation. With regards to bilateral stimulation versus unilateral stimulation, I'm not aware of any head-to-head clinical studies comparing the two, so I can't make any comment there. In terms of superiority of bilateral stimulation for supine AHI, I haven't seen any comparative data there either. Inspire therapy has, there's numerous studies, including a study that was just published by Cleveland Clinic, Florida in August of this year, showing excellent improvements in supine AHI in both positional and non-positional OSA with Inspire therapy. But with regards to, bilateral stimulation, I haven't personally seen any data published that it's definitively more superior in, superior supine OSA versus unilateral stimulation.
Okay. And, one of the things that I read in the DREAM study was, again, that's the Genio study.
Okay.
For the listeners, is that the patients had a very similar inclusion criteria. So they definitely wanted to see them sleeping on their back, and they wanted to see what the difference is. They wanted to make sure they had back sleeping as well as side sleeping on their polysomnogram. So everybody in the trial actually had polysomnograms or in-lab sleep studies for those who are listening. That is the, quote, gold standard. So we really love when we can get polysomnogram data versus home sleep apnea testing. And especially in trials, it's very great to be able to have that kind of information. They did undergo drug-induced sleep endoscopy, and the criteria otherwise were very similar. They had a similar BMI to the original STAR trial, was a BMI of 32 or below, and their AHI criteria was sort of the older criteria before the expansion, with Inspire being out a lot longer. What's interesting to me is that when I was looking at what you need to do in order to get this device, they no longer required drug-induced sleep endoscopy. And I found that fascinating because I thought the whole purpose of drug-induced sleep endoscopy was really to determine, hey, how does your airway close off? And are we going to get a good response? Because if the side walls are collapsing, or you have a combination of both the tongue and the side walls, you may not get as great an optimal response. I wanted to hear your thoughts on why that is, that they would no longer need that. Is that follow-up trial that you were just mentioning that they're doing looking at concentric airway collapse?
So I guess there's a couple of points to clarify here. So the purpose of the drug-induced sleep endoscopy is to specifically rule out individuals that have complete concentric airway collapse at the level of the VLL pharynx, right? So those individuals, that have the lateral collapse, or almost like a circular collapse at the level of the soft palate, those individuals can't benefit from hypoglossal nerve stimulation as far as we are aware right now. Both studies, the STAR trial and the DREAM study, did require DICE to rule out patients with triple C or complete concentric airway collapse. With regards to the DICE requirement, that actually is an insurance requirement. It's a payer requirement of using DICE to rule out triple C patients. So right now, and even on the FDA label for Genio, it does indicate that the device is not indicated for patients with triple C. And right now, the only way to rule out a patient with triple C is with a drug-induced sleep endoscopy. So there, as far as I'm aware, there's been no change in that requirement, and it's a payer requirement, right? It's not an FDA requirement for the DICE.
Okay.
It's a payer requirement. The FDA label indicates not, indicated for patients with triple C, and both therapies have similar labeling, but the DICE requirement actually was instituted by insurance payers. So.
Okay. And what's your understanding in terms of, so let's level set, because you've said it several times now, and I want to also reiterate to the audience that there have not been a trial where they have, here, you're in the Inspire trial, and you're going to do Inspire on you. And then this arm, we're going to do Genio, and the other arm, we're going to do some form of a sham or what have you. We don't have that. Again, it's not comparing apples to apples. That being said, the outcomes for the individual study looking at Genio, if you compare that with the individual study looking at STAR trial, just from face value, like what was published, similar number of patients, it seemed as though the outcomes seemed, in terms of response, seemed to be similar. Is that your understanding? Because, I am just a sleep nerd, but I'm not going to call myself some statistician. So if you think there are particular things people need to understand about these different trials, what's your thoughts now that we have this newer technology?
It's a great question. It's an exciting time, right? And I'll start with that first. It's an exciting time for what I call the neglected patients. And what I mean by that is the patients that couldn't tolerate PAP therapy, and they tried and just stopped showing up, and they were not to be seen again because they didn't think that any of us had any other alternative options for them. And I started implementing Inspire in 2019. The number of patients that I saw come back that I hadn't seen in 8-10 years, I was like, oh man, great to see you again. Like, what happened? Like, I tried and tried and tried, doctor, and I just couldn't do it. And I didn't really think that there were any other viable options that you could offer me. So I didn't want to come waste your time. And that was the honest truth. But so how have you been feeling? Like, I'm still sleeping poorly. I'm still snoring, and I'm still sleeping in a separate bedroom. I'm still tired. Right. So from that standpoint, and that's a story I think all of us in sleep medicine hear over and over and over again. So first off, having alternative therapies in this space of hypoglossal nerve stimulation therapy is great for patients, right? It's giving us as a field the opportunity to show our patients that, hey, we're not only focused on the new diagnosis, we also now can shift part of our focus on the patients that were previously diagnosed that are not using therapy because they couldn't tolerate PAP therapy, but they're suffering consequences both from a subjective and objective standpoint because of their untreated moderate severe OSA. So from that standpoint, like, I'm all for alternative therapies. But when I make a decision, like with anything, right, I'm going to look at the trial data with a fine tune, with a kind of a close lens in terms of what did the studies show, like what was the attrition, what was the adherence? Because adherence in this space is extremely important. I mean, adherence with CPAP therapy, we know, is, over 3 years is less than 50%, probably less than that even if you get into the weeds. So if a patient is not using any therapy, no matter how effective it is, it's not an effective therapy, right? And us calling CPAP a gold standard is a problem, because how can a therapy be considered a gold standard if more than half the patients over time stop using it, right? It's not, you can't call it a gold standard. But getting back to your question, for me, when looking at any clinical study, I'm going to look at the attrition, how many patients actually dropped out, right? With the STAR trial, the attrition was very low. I believe it was less than 2%. With the DREAM study, the attrition was about 23%. Then serious adverse events related to the procedure or the device. In the STAR trial, that SAE was less than 2%. In the DREAM study, I believe it was probably closer to about 7 to 8%. And then adherence is also important as well. Like, how well do the patients use therapy? Because it doesn't matter how beautiful the therapy is and how effective it is at improving AHI. If they're not using it, then that's a concern for me as a clinician, because at the end of the day, I want to make sure that I'm collectively making a decision with my patient for a treatment option that I know that there's a high likelihood that he or she is going to be able to use it, right? Because with any surgical therapy, like, the last thing any of us, I think, would want as physicians is to say, hey, we're going to send you down this pathway of getting a surgical implant that I'm skeptic partly of whether or not you're going to be able to use it successfully. And it's important to have a full disclosure discussion with the patient in terms of what's involved in using it, right? A lot of patients, just don't fully understand, even when it comes to CPAP therapy. I've had patients come in and say, I didn't realize I had to change the filter every 2 weeks, and I didn't realize I had to put distilled water. I didn't realize to wash the container every day, and yada, yada, yada. And that in turn results in patients saying, I'm not going to do this. And I'm a CPAP user, and I get it. I understand the nuances of having to do this every day. But those are the important things. And with regards to adherence, the STAR trial adherence greater than 5 nights per week was roughly around 91%. In the DREAM study, it was about 52%. Obviously, different numbers for both studies. The SHARE 20 AHI response rates were very similar between both the STAR trial and the DREAM study. So with regards to improving AHI, both were very comparable in terms of the outcomes, right, in both studies. So.
First of all, we're not taking sides here. So I'm going to use the term devil's advocate, but it's not really a side. It's just also pointing out some of the things that I think are kind of cool that would make me excited as a patient to be like, oh, would be that it's one incision. And then the other would be that it you don't have to worry that you're going to need to change or have a future procedure theoretically, because it doesn't have the battery is external. And I believe even the Inspire 5, I think the lifespan for the device is still approximately 11 years, or has that extended? Okay. Yeah. So
the published lifespan for the Genio implant is 12 years. So it's a 1-year difference. So.
Okay. Interesting. So when you say lifespan, is that you still might require another procedure even if the battery is external?
Yeah, the paddles. I believe it's related to the paddles.
Okay.
Longevity of the actual paddles or paddle, I believe they refer to it, that they place, on either side. Mm-hmm. So, but yeah, the label actually indicates 12 years. So it's a 1-year difference between the two. So.
All right. So that's not really a big difference. I'm curious where you think, is this just one of those situations where we're just going to have multiple options and it is what it is? Or do you foresee, have a better sense of which phenotype of patient, maybe the type of patient that might benefit from one over the other? Or do we just not know that information at this point because it's so new?
We don't know. I mean, I can't give you, there's no data, like I said earlier, that compares the two therapies, right? So from a phenotype standpoint, the labels are basically the same right now. I mean, both of them are not indicated for complete concentric airway collapse. DICE is still required as per payer requirements. It's the payers that require that examination. I think there's a lot of anecdotal stuff that's being shared out there, amongst physicians in terms of, I think this patient may be a good candidate. Or this patient may be a good candidate for Genio versus Inspire. But from an objective standpoint, there is no data looking at which phenotype is definitively better for Genio versus Inspire. So I think only time will tell. So,
all right, that's fair. I'm going to be really curious to see where this goes. I've heard of some concerns related to, and it could just be technique and the fact that it's a new procedure, device migration with Genio. That's been one of the, sort of more, one of the criticisms, I guess, if you can label it that, or one of the observations, maybe more accurate. It's interesting that you emphasize the DICE as being just a payer selection. So if you were a payer, this is a hypothetical, what would be the argument to stop the DICE? Because it sounds like to me, part of the reason that we know that these devices are working is specifically how the airway collapses. So even though it's a payer requirement, removing that information, wouldn't that be a disservice to a patient undergoing a surgical procedure? I'm curious to know your thoughts on that.
I don't think so. I would take a look at the predictor study that was, I think it was presented last year and it's published now, but I don't believe it would be. So, the population of patients, and I can tell you from my population, and I'm just giving as a sleep specialist, this is not from Inspire, just in my patient population, for the patients that I referred for Inspire therapy, regardless of BMI, I would say anecdotally, maybe less than 10% had complete concentric airway collapse. So it's not as common as that we as a field suspect that it is, right? Obviously, as the BMI increases, there is a higher chance of potentially having complete concentric airway collapse, but it's not a one-to-one correlation. So knowing that, I don't think that it would be a disservice to patients.
Really? Interesting.
And keep in mind, right, we've got other alternative therapies as well, like the Zepbound for OSA, right? So
weight loss. I think there was a recent trial published, right? There was somebody who, I think it wasn't necessarily a prospective analysis, but it may have been a retrospective analysis looking at the success of Inspire specifically in weight loss, and people who lost weight tended to see better improvements in AHI.
Yeah, well, but I'll give you an actual real life example from my practice. We had a patient who could not tolerate PAP therapy, had a BMI of about 36, had a baseline PSG AHI in the low 90s. He was referred to ENT. This is just a year ago. He was referred to ENT, had a drug-induced sleep endoscopy to evaluate for Inspire. He did have complete concentric airway collapse, so he was immediately disqualified. He was then placed on, I believe at the time it was probably semaglutide because it wasn't FDA approved for the OSA indication. But he lost, and he was symptomatic. He had daytime hypersomnolence, poor quality sleep, snoring. He ended up losing a significant amount of weight to where his BMI did drop down to about 32. But because he was still symptomatic, he was reevaluated in the sleep lab. His AHI reduced from the low 90s down by at least 50%. But he was still symptomatic. So he was referred back to ENT to do a new drug-induced sleep endoscopy. His triple C was completely resolved. And he was implanted with Inspire, and he's doing extremely well. So, and his AHI improved dramatically to less than 10, and he's asymptomatic. So, that's another thing to keep in mind as well, is that there's ways to think outside the box on a patient, like we did in that gentleman's case of, all right, you've got a high BMI, you've got triple C, you're symptomatic, you've got very severe OSA. We know that there's a higher likelihood that if you lose weight, the triple C can potentially resolve, and there's likely going to be improvement in your AHI. So let's address that first. Let's see how you do. If you're still symptomatic, you still have moderate severe OSA, then let's try again. And it was a good outcome. Those are things that we felt.
That's a great story. And that's consistent. I just was able to pull it up. This was from Dr. Hahn, who's at Pittsburgh, where I know they did a lot. I think they did the original STAR trial over at Pittsburgh. It was a retrospective case review, but it was but your experience are sort of mimicked there, where they're getting a bigger bang for their buck. So I'm happy that you brought that up. I'm going to play devil's advocate. And my opinion is, I think that having that extra information, such as a DICE, I think even if it's just 10% of your patients before my patients undergo a surgical procedure, even if it's relatively mild a procedure, which I would consider these implants to be so. These are not heavy duty, crack the thoracic cavity and do crazy surgery type of surgeries. But I would make the argument I would want to know what's the likelihood of my response.
Like that, yeah.
Oh, okay.
What would you do for this patient otherwise?
Are you talking about the one that you were just speaking of using? I love what you did.
In the case that the payers got rid of the DICE requirement, right? And you have a patient that is obese, that has moderate severe OSA, they're clearly symptomatic, they've got hypertension, AFib, and they cannot tolerate PAP therapy. What would you
100% definitely emphasize the weight loss piece if they were willing, especially because we know the reason people are heavy is because obesity really is a disease process unto itself, and it can't be separate. And I think knowing that and knowing that there's medications that could assist them in moving in that right direction, getting them, of course, the comprehensive lifestyle intervention and coupling that with some form of a GLP-1, and obviously indicated is tirzepatide, I think is the right way to go for them. I think where you're getting at is would I consider referring them for ENT if I knew that their BMI was 40 or below and they met that criteria. That would be an option that I would put on the table for them. But the flip side is I still think it would be really nice to truly, and it also might be helpful for the patient and motivating for the patient to go, hey, I may not be a candidate now, but in the future I might be if I get this weight down. I think that's more information to be had. And I think what you did was very clever in your approach and would be the exact data points that I would be curious to have. Again, if it's not a requirement, it's not a requirement. And then I think you just make your best guess. But I think having that additional information has utility.
But you don't have to make the best guess, right? Take a look at the predictor study. There's valuable data there that was collected in, I believe, over 600 patients. And I think you'll be surprised there. So to show, and I'm not advocating for getting rid of DICE, but you being devil's advocate, I'm also being devil's advocate as well, which is why I enjoy talking to you. No, I mean, take a look at it. But like what I'm getting at is like, and I think it's a paradigm shift for all of us, right? As sleep clinicians is like, do we always have to have the perfect patient? Who is a perfect patient? Can we predict the perfect patient? I don't believe we can, right?
Perfection needs to be thrown out the window in our personal lives too.
100%. It's a larger question, in my opinion, personal opinion as sleep physicians, is do we tell a patient that's clearly symptomatic, clearly at risk, or has cardiovascular consequences because of untreated moderate severe OSA that, hey, I just don't think you're a perfect patient, so I'm not going to refer you for a potential treatment that may not have a perfect outcome, but even if it improves them by at least 50% objectively and it results in subjective improvement, wouldn't that be a win? What's better, leaving a patient symptomatic with an AHI of 65, and because we don't think this person's a perfect patient, I'm not going to refer. I'm going to recommend weight loss. Let's say the payer doesn't approve. I have a patient right now whose payer will not approve Zepbound for moderate severe OSA. And they can't afford out of pocket, like Lilly Direct, right? They can't afford it. So they're kind of stuck with not being able to address the weight loss. And they've done every lifestyle modification and all that, regular stuff. What do we do in that situation? Do we tell them, sorry, I just don't think you're the right candidate. We're not going to do anything for you, rather than, hey, there's a chance that we can get at least 50% improvement. I think that's better than not doing anything at all, right?
I think we're 100% aligned there. Yeah. We need to have options. And that's what makes these discussions so fun and so cool, is that this isn't about like, oh, I work for this, so therefore I'm going to say that. It's about, what the heck do we do to move the needle on our patients? I'm very excited, too, to see what the future holds for things like Apnea product. I mean, are they going to get FDA approval? And then we may have an actual oral pill that helps increase muscle tone, which is also really cool. And maybe in combination, what do we do with that,
I agree. And we're moving towards special, like kind of becoming more specific for our patients, right? I firmly believe that there's a role for combination therapy in all of these patients, almost like in cardiology, right? When a patient has a cardiac issue, they're not just addressing one thing. They're not putting everyone just on a beta blocker. They're looking at blood pressure. They're looking at inflammation. They're looking at cholesterol, like treating a multitude of things, right? So I think the same thing is slowly occurring in the OSA realm as well. It's an exciting time. I mean, it's great to be in the field, right? Compared to 10 years ago and 15 years ago, and it was mask on, mask off.
I know. So much more fun, I must say. So much more fun.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com. And start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.